Mary Ryan, Acting Principal Lead, System Safety Culture at the CEC, shares ways to enhance teamwork and communication and the impact on patients and families when things go well.
So it was a winter's day a few years ago when my mum, Kath, who was 86 years old at the time, had to undergo emergency surgery. During the week that my mum had to spend in the hospital, the staff took the time to understand what made her happy and what would ensure her comfort. Mum and someone from the family were not only updated daily on the plan for her care, but we were all included in the decisions about her care. Mum's comfort was ensured by the care and attention of staff from different teams who all shared the same goal. And we know this because they all told us the same story, no matter what team they represented. By the end of the week, Mum was well enough to be transferred back to her aged care home, where she was in familiar surroundings amongst friends and able to receive the next stage of her care, which is exactly where we wanted her to be. This sort of person-centred care or coordinated care that my mum received won't occur without established multidisciplinary team communication processes that are valued by everyone. So to make it easier for teams to keep older people safe, the CEC has developed the Comprehensive Care Minimising Harm model. So knowing that safety depends on good teamwork and communication, the model includes the building blocks for a safe ward, and these are communication processes which occur regularly, where all members of the multidisciplinary team are kept up to date by sharing from their perspective what's happening with every patient, such as what's improving, what just doesn't seem right, and what needs closer observation or investigation. For example, in clinical handover, this is an important way to transfer care, but it usually happens amongst single disciplines at set times of the day. Whereas a huddle is brief, it involves a multidisciplinary team, and happens in between handovers. So, for example, in one huddle, the team heard from a catering staff member that Mr. Smith in bed 4 wasn't drinking any of the fluid that had been left for him. It was then shared that he actually hadn't had his bowels open for a couple of days. There was a speech pathologist in the huddle who questioned whether Mr. Smith had issues with swallowing, while another team member shared that Mr. Smith needed help mobilising, but he never liked to bother staff, so perhaps he was restricting his fluids for that reason. So the team made a plan to speak with Mr. Smith and his wife at the end of the huddle to get their insights. And as you can see, with the help of multiple perspectives, Mr. Smith's care is more comprehensive and problems are more likely to be addressed quickly. So if the subtle changes in Mr. Smith's condition weren't picked up early, he would have quickly become dehydrated and more constipated, which could have led to a delirium. And this is why the building blocks for a safe ward are all linked and literally build on each other, so that the rapidly changing nature of patient care can be observed by all members of the team on a regular basis. So let's have a quick look at the building blocks. With clinical bedside handover, this occurs at the change of every shift. Clinical staff use 7 key principles to transfer patient care from one professional to another. Whereas safety huddles are brief, multidisciplinary, and include clinical and non-clinical staff. Strong leadership means all staff feel empowered to speak up for safety. They follow a 3-point agenda. Firstly, we look back. What happened in the last 24 hours? What went well? Was there an incident? Have we prevented that from happening again today? Look now. Who or what is our greatest risk? What could get in the way of safer care today? Such as workforce issues, for example. And 3, action and accountability. What do we need to do to ensure safety for everyone? And who's responsible for any actions? Whereas multidisciplinary team rounds are a care coordination round that happen once or twice each week. The multidisciplinary team meet at the patient bedside to gain insights from the input of multiple perspectives, including the patients or their carers, to ensure everyone's on the same page. Intentional patient rounding. So this is a purposeful, proactive communication process where each hour on every shift, a healthcare team member will check in with the patient and or their family or carer. Post-incident huddle occurs as soon as possible after an incident occurs. the team will come together to review the issue that led to the incident in a non-judgmental way and view the process as a learning opportunity. And underpinning all of this is data intelligence. This is where real-time data is made available to the team and reviewed regularly to look for areas of improvement and to ensure that any changes are leading to an improvement. So in summary, as George Bernard Shaw said, the single biggest problem in communication is the illusion that it's taken place. So great, person-centred, coordinated care occurs when there are established multidisciplinary team communication processes that are valued by everyone. This takes time, commitment, and good leadership to achieve. We all play a part in achieving safe care. At the CEC, we've developed resources to help teams implement the building blocks for a safe ward. And these can be found on the CEC website.